intense. He's dedicated. He catches shoplifters. He checks IDs. He makes sure the coffee machine is turned off at night. I mean, he is the perfect protector.
I'm getting the sense this security guard is a metaphor for something biological.
Oh, absolutely. He's the
Yeah.
immune system.
Yeah.
But here's the twist. One night, a single intruder breaks in. Just one guy, maybe cracking a window on the ground floor. Now, a rational security guard would tackle the guy, maybe call the police.
That would be the standard healthy response, the proportionate response.
Right. But our guard, he snaps. He panics completely. He locks all the automated doors so nobody can leave. He cuts the power to the elevators. He turns on the fire sprinklers and floods every single hallway. And then, just to be absolutely certain he got that one intruder, he lights a match and sets the entire building on fire.
That is a terrifying image. But if we are talking about the topic I think we're talking about, it is also a stunningly accurate analogy.
It is. We are looking at a biological civil war. We are talking about a condition where the body's defense system turns against itself with such ferocity that it threatens to burn down the building, the human body, just to catch a germ. Today, we are doing a deep dive into sepsis and septic shock.
This is one of those topics that feels like it should be, niche medical knowledge, but it's actually something everyone really needs to understand. Sepsis is so widely misunderstood. It's often missed until it is far, far too late. And the stakes, well, they couldn't be higher.
We are working off a very dense, incredibly detailed medical text today. It's Chapter 45, Sepsis and Septic Shock. And I want to get straight to the bottom line because the numbers in here they stop me cold.
You're looking at the mortality statistics? I take it.
I am. The source explicitly describes shock as the most ominous complication of gram-negative sepsis. And it says it causes death in about half of patients, 50%. In modern medicine, with all our technology, a coin flip determines if you survive.
That is the reality. And that's why this deep dive is, like you said, more of a mission than a lesson. We need to understand the vocabulary of this crisis, identify the invaders, watch the mechanism of the collapse, how the building burns down, and then look at the counterattack. How do doctors try to save the structure before it's ash?
Let's start with that vocabulary. I think a lot of people hear sepsis and just think bad infection. Like, oh, the cut on my leg got septic. But medically, that's not quite right, is it?
Not at all. And precision really matters here because the treatment path depends on exactly where you are on this spectrum. The text makes a really important distinction right out of the gate. Before we even get to sepsis, we have to understand something called SIRS, S-I-R-S.
Systemic inflammatory response syndrome.
Correct. And you can think of SIRS as the building's main fire alarm going off. It's a systemic response. And here's the key takeaway. SIRS can be caused by an infection, sure, but it can also be caused by non-infectious insults. A bad burn, severe trauma, pancreatitis. It's just the body screaming, something is seriously wrong.
So how do I know if I have SIRS? Is it a feeling, a vibe?
It is definitely not a vibe. It is a strict checklist. To diagnose SIRS, you need 2 or more specific physiological conditions. It's not subjective at all.
Okay, run us through the checklist. What are we looking for?
First, temperature. We usually think of fever, right? Greater than 38 degrees Celsius. But, and this is so crucial, hypothermia counts too. If you drop below 36 degrees Celsius, that is also a sign the system is crashing.
Which is interesting because we associate being sick with being hot. But cold can be just as dangerous.
Cold is often worse, actually. It implies the body is losing the energy battle. Next is heart rate. Tachycardia, specifically a heart rate greater than 90 beats per minute. The heart is racing to try and pump blood to tissues that are screaming for oxygen.
Okay, so fever or cold and a racing heart. What else?
Respiratory rate. So, breathing rate. Greater than 20 breaths per minute. You're panting, essentially. Or, if we look at blood gas, a PaCO2 of less than 32 millimeters of mercury.
That's carbon dioxide, right?
Yes. When you breathe that fast, you blow off CO2. It's a compensatory mechanism. And finally, we look at the white blood cells.
The army.
The army. The count is either elevated, so greater than 12,000, meaning full mobilization, or, and this is ominous, it's crashed to less than 4,000.
So the army has been wiped out.
Exactly.
Huh.
Or you see something called band forms, greater than 10%.
The text mentioned these band forms. It sounded really bad.
It's basically the body becoming desperate. Band forms are immature white blood cells. They aren't fully developed. The bone marrow is essentially conscripting children and sending them to the front lines because the regular army is gone.
That is a chilling way to put it. Sending children to the front lines. So if I have 2 of those things, say a fever and a racing heart, I have SIRS, but I don't necessarily have sepsis yet.
Correct. Sepsis has a very simple mathematical definition, really.
Yeah.
Sepsis equals hours plus a confirmed or suspected infection. You need the alarm bells and the intruder.
But the slide down the hill doesn't stop there. The text outlines a progression. We go from sepsis to severe sepsis. What's the tipping point there?
Organ dysfunction.
Yeah.
That's the line in the sand. Severe sepsis is when the infection and the body's response starts breaking the machinery. We start to see hypoperfusion.
Hypo meaning low, perfusion meaning blood flow, so low blood flow.
Exactly. Blood isn't getting into the tissues properly. So you see altered mental status because the brain isn't being fed. You see low urine output because the kidneys are shutting down to save water. You see lactic acidosis.
Let's pause on lactic acidosis for a second. I know athletes get lactic acid buildup when they sprint. Is this the same thing?
It's a similar mechanism, but a much, much more dangerous context. When you sprint, your muscles run out of oxygen, and they switch to anaerobic metabolism burning fuel without air. That creates acid. In sepsis, your whole body's doing that, not because you're running, but because the blood simply isn't delivering oxygen. Your cells are suffocating while you're lying in a hospital bed.
And then we hit the real danger zone, septic shock.
This is the definition that scares every doctor. Septic shock is sepsis with hypotension low blood pressure that persists despite fluid resuscitation.
So you've pumped them full of fluids to fill the tank, and the pressure's still dropping.
The pressure is hitting the floor. At this point, fluids aren't enough. You have to put them on drugs, vasopressors, just to chemically squeeze the veins tight enough to keep blood moving to the brain and other vital organs.
And there's one level even deeper than that mentioned, refractory septic shock.
The word refractory essentially means stubborn or unmanageable. This is when you are blasting the patient with high doses of dopamine or norepinephrine. We're talking massive chemical support, and the blood pressure still won't come up. The system is fully dilated, it's collapsing.
Which leads to MODS, multiple organ dysfunction syndrome.
The end game. The kidneys stop working, the liver fails, the lungs fill up with fluid. You are now using machines to do the work of the organs just to maintain homeostasis. It is a domino effect of total systemic failure.
Okay, wow. We've mapped out the disaster. We know what the building looks like when it's burning. But let's rewind a bit. Who lit the match? Who are these invaders?
The source material gives us a pretty clear breakdown of the usual suspects, and the leader, the most common entry point for this whole invasion, is the lungs.
The respiratory tract?
By a huge margin, somewhere between 39% and 50% of sepsis cases start as pneumonia. And it makes sense if you think about it. The lungs are a massive surface area. I mean, like a tennis court's worth of delicate tissue exposed to the outside air with every single breath. It's the easiest gate to crash.
What about the other entry points? Where else does it start?
The urinary tract is next. That accounts for about 5% to 37% of cases. So infections creeping up from the bladder to the kidneys. And then you have the intra-abdominal space, about 8% to 16%. That's things like a burst appendix or a perforated bowel.
So lungs, urine, belly. Those are the main gates. Now let's talk about the specific bad guys, the actual pathogens. The text breaks them down into gram-negative and gram-positive bacteria.
And gram-negative bacteria are the heavyweights here. They cause about 52% of cases. The source lists the common ones like E. coli, Klebsiella, and Pseudomonas aeruginosa.
I noticed the text flagged Pseudomonas specifically. It seemed to treat it with a special level of, fear.
It did, and for good reason.
Yeah.
Pseudomonas aeruginosa is highlighted as the most frequent cause of sepsis fatality. You can think of it as the terminator of bacteria. It's incredibly resilient. It's often resistant to many antibiotics, and it just hits so hard. Other bad actors in that group include Serratia and Enterobacter.
And then we have the gram-positives.
About 37%. This is your Staphylococcus aureus. Everyone knows staph and streptococcus pneumonia, a common cause of pneumonia.
Then there's this small slice of the pie, just 5% for fungi. My instinct is to sort of ignore 5%, but the text warns us not to do that.
Do not ignore the fungi. Fungal sepsis is rarer, yes, but it is incredibly deadly. The main culprit here is Candida albicans. The crude mortality rate for candidemia, that's fungus in the blood, is over 35%.
Why is it so deadly? Is the fungus just stronger than the bacteria?
It's not necessarily strength. It's more about stealth and the difficulty of treatment. Fungal infections often happen in patients who are already very sick or immune compromised. And unlike bacteria, where we have fast, effective drugs, fungal treatments are slower and can be harder on the body. Plus, doctors often don't even suspect fungus until the antibiotics have failed. By then, the fire is just out of control.
That makes perfect sense. It's the enemy you don't prepare for. Now, I really want to get into the mechanics, the how, Because this is where that whole Civil War idea really comes to life. The text gets very granular about what happens when a gram-negative bacterium enters the system.
This is the pathophysiology section, and it is fascinating.
Yeah.
It all revolves around a specific component of the bacterial cell wall called endotoxin, specifically a molecule within that called lipid A.
Lipid A, it sounds so innocuous, like a vitamin or something.
It is anything but. To the human body, lipid A is a nuclear launch coat. It's a piece of the bacteria's armor. When the bacteria dies or sheds its outer membrane, lipid A is released into the bloodstream.
So the intruder drops a badge. What does our security guard do?
He goes completely nuclear. The endotoxin binds to a protein in the plasma, and that whole complex floats around until it finds a specific receptor. It's called CD14 on a macrophage.
And the macrophage is like the tank of the immune system, the heavy infantry.
Right. And once that key turns in the lock lipid A hitting CD14, the macrophage activates. But in sepsis, it doesn't just, eat the bacteria and move on. It panics. It releases a massive wave of chemical signals called cytokines.
The text calls this the chemical storm.
And it is a storm. The primary mediator is TNF-alpha tumor necrosis factor alpha. You can think of TNF-alpha as a general screaming attack over the loudspeaker to the entire body. Along with it comes interleukin-1 and interleukin-6. These are all pro-inflammatory. They tell every cell in the vicinity to inflame, to attack, to swell up.
But the body has checks and balances, right? It shouldn't just burn forever.
It tries to stop. And this is the absolute chaos of sepsis. While the general is screaming attack, another part of the immune system is releasing anti-inflammatory mediators, things like IL-4, IL-10. They're screaming stop. So the body is hitting the gas and the brakes at the exact same time. It's pure physiological confusion.
And the battlefield where all this plays out is the endothelium.
The lining of your blood vessels. This is so crucial to visualize. Your blood vessels are usually these smooth, tight pipes, but the inflammation attacks those endothelial cells. They start to separate, they get leaky.
So the fluid that's supposed to be inside the pipes carrying red blood cells starts seeping out into the walls, into the surrounding tissue.
Exactly. It leaks out into the tissues. This causes massive swelling, but more importantly, it means there's less liquid volume left in the pipes to maintain pressure. This is the fundamental reason why blood pressure drops.
But it gets worse. The text talks about coagulation. This part sounded like a complete paradox to me.
It's the cruelest part of sepsis. The endotoxin also activates something called the complement system, which makes the blood sticky. Platelets start clumping together.
Okay, so we get clots.
You get microclots. Millions and millions of tiny little clots forming in the capillaries all over the body. These tiny clots block blood flow to the organs, killing the kidneys, killing the liver, bit by bit.
But then the text mentions bleeding. How can you be bleeding if you're clotting everywhere?
That is the absolute horror of DIC-disseminated intravascular coagulation. You are forming so many useless microclots everywhere that you literally run out of clotting factors. You consume your entire supply. So if the nurse tries to put in an IV line, or even just from the gums, the patient starts bleeding uncontrollably. There's nothing left to stop it.
So you have massive clotting shutting down your organs, and at the same time, massive bleeding because you have no clots left. It's a complete biological deadlock.
Precisely. And while all this is happening, the body's natural peacekeepers, like a substance called activated protein C, which is supposed to stop clots, are depleted. The levels just plummet. So there is no break on the clotting until you run out of fuel.
That vividly explains why the mortality rate is so high. I mean, you're fighting a war on every single front simultaneously. So let's step out of the microscopic view for a minute. If I'm a clinician or a family member standing by the bed, what does this look like?
The source does a great job of distinguishing between two distinct phases: early sepsis and late sepsis. And the shift is almost like a switch flipping from hot to cold.
Walk us through early sepsis. This is the warm phase, I take it.
Yes. The body is still fighting hard. The patient has a fever. They're shaking with chills, what we call rigors. Their heart is racing. They're breathing fast. And interestingly, they often have hyperglycemia, high blood sugar.
Because the body is just dumping all its energy reserves to fight the war.
Exactly. They are revved up. Their skin might even feel warm and flushed because all those blood vessels are dilated.
But then they start to lose. Late sepsis begins.
This is the cold phase. The fever breaks, but not in a good way. They become hypothermic. The high blood sugar crashes into hypoglycemia. The blood pressure bottoms out. That's the hypotension.
And their mental status.
Coma. The kidneys stop making urine, which is called oliguria. The white blood cell count drops, which is leukopenia. The system is it's shutting down.
There was a term used in the text that I really want to unpack, the hemodynamic paradox. It describes a unique state in septic shock involving cardiac output.
This is really important for understanding why treating this is so hard. Usually when someone goes into shock, like if they have a heart attack, what we call cardiogenic shock, their cardiac output is low. The pump is broken.
Right, makes sense.
But in septic shock, especially early on, you have a hyperdynamic state. The heart is pumping furiously. You have high cardiac output. But at the same time, you have very low systemic vascular resistance.
The resistance is low, meaning the pipes are just wide open.
Imagine a fire hose. If the nozzle is tight, you get high pressure. If you cut the hose open down the middle, the water just spills out with no force. In sepsis, the inflammation has dilated all the blood vessels. They've blown wide open. So even though the heart is beating its absolute hardest, it's just pushing blood into a slack, leaky system. The pressure drops despite the pump working overtime.
That is a great visual. The pump is fine, but the plumbing has lost all its tension.
Precisely. And that dictates exactly how we have to treat it.
Which brings us to the counterattack, the Surviving Sepsis campaign. This sounds like a military operation.
It basically is. The goals are simple but urgent. Diagnosis, source control, antibiotics, and interrupting the shock sequence. And we are working against a clock, a very, very fast clock.
The golden 6 hours.
This isn't a suggestion. It's a grade 1C recommendation in the guidelines. There are specific targets called early goal-directed therapy. You absolutely must try to hit in the first 6 hours to save the patient's life.
Let's look at these targets because they tell us exactly what the doctors are trying to fix. First, CVP central venous pressure. Target, 8 to 12.
CVP is a way to measure how much fluid is returning to the heart. A low CVP means the tank is empty. We need to fill the tank fast.
Second, MAP mean arterial pressure. Target, 65 or higher.
This is the overall pressure in the lines.
Yeah.
If it's below 65, the brain and the kidneys just aren't getting fed. We need to pressurize the whole system.
Third, urine output, 0.5 milliliters per kilogram per hour.
Urine is the window to the kidneys. If they are making pee, it means they're getting blood flow. If the pee stops, the kidneys are dying. It's that simple.
And finally, central venous oxygen saturation, target, 70%.
This is like checking the exhaust pipe of a car. It tells you if the tissues are actually extracting and using the oxygen you're delivering. If this number is off, it means even if blood is getting there, the cells themselves are too sick to use the oxygen properly.
So how do we hit these numbers? Step one seems to be fluid, a lot of it.
Massive amounts of fluid. Fluid resuscitation is the best initial intervention. We have to refill those dilated, leaky pipes.
But there's a debate here that the text spends some time on. Crystalloids versus colloids. This seems like a Coke versus Pepsi debate for doctors.
It's a little more high stakes than soda. But yeah, crystalloids are things like normal saline or lactated ringers. They are essentially just salty water. Colloids are thicker substances, like albumin or a synthetic called hetastarch.
I see the debate here. Colloids are the premium option, right? They're designed to stay in the veins better.
Theoretically, yes. Because crystalloids are just water and salt, they leak out of the vessels very fast. And remember, the vessels are already leaky, so you need to pour in 2 to 4 times as much saline to get the same pressure boost you'd get from albumin.
So why wouldn't you just use the premium stuff every time? Why flood the patient with all that saline?
Well, cost is one big factor. Albumin is very expensive. But also, some of the synthetic colloids have risks. They can actually hurt the kidneys. And here's the real kicker. The big studies show no significant difference in survival.
Really, after all that?
Dead even. Whether you use the cheap stuff or the expensive stuff, the survival rates end up being about the same. So generally we start with crystalloids. Unless the patient's own albumin levels are critically low already, then we might reach for the premium shelf.
Okay, so we're flooding the system with fluid, but we still have the intruder. We have to kill the bacteria.
Antimicrobial therapy. And if you thought the 6-hour window was tight, this one is much tighter. The guidelines say IV antibiotics must be started within 1 hour of diagnosis.
1 hour. But it takes days to grow a culture and see what bacteria it is.
Exactly. You don't have time to know for sure. You have to guess. This is called empiric treatment. It's basically educated gambling with life or death stakes.
So how do you make that educated guess?
You look at the clues. Did the infection the community have a lot of a certain resistant bug? You use broad-spectrum antibiotics that act like a carpet bomb. You try to hit everything you can.
The text lists some specific weapons here. Let's say you suspect that Terminator bacteria, Pseudomonas. You can't just use basic penicillin, right?
No, you'd be bringing a knife to a gunfight. If you suspect Pseudomonas, you need the heavy artillery. You're using things like ceftadime, cifetamine, or carbapenem. You absolutely cannot risk missing it.
What about MRSA, methicillin-resistant Staph aureus?
Then you need vancomycin, or another drug, linezolid.
The text made a really interesting point about linezolid versus vancomycin specifically for pneumonia.
This is a great clinical detail. Vancomycin is a huge molecule. It's physically large. It has trouble crossing from the bloodstream into the lung tissue. Linezolid is smaller and penetrates the lungs much better. So if the war's in the lungs, linezolid might be the better sniper.
And once you finally get the lab results back, maybe 48 hours later, you stop carpet bombing.
Yes, that's called de-escalation. As soon as you know the enemy, you switch to a narrow-spectrum antibiotic that targets only that specific bug. It saves the patient from side effects and, importantly, prevents creating more antibiotic resistance.
Okay, back to the hemodynamics. We've given fluids, we've started antibiotics, but the patient is still hypotensive. The pipes are too loose, and the fluid isn't working on its own.
This is the very definition of septic shock.
Yeah.
Now we have to move to advanced support. We need vasopressors.
Pressors. The name implies what they do.
They press, they squeeze. We use these drugs to chemically force the blood vessels to clamp down.
And what's the drug of choice for that?
Norepinephrine is the first choice. It's a potent alpha-adrenergic agent. It's very effective at tightening the vessels to bring that MAP up to our goal of 65.
And if that doesn't work, if the pressure is still low,
We might add a second agent, like vasopressin, or in some cases, epinephrine.
epinephrine is adrenaline, right? The Pulp Fiction shot to the heart.
It is, but in this context, it's a last resort. It whips the heart and squeezes the vessels, but it comes with a cost. It dramatically increases the heart's oxygen demand and can reduce blood flow to the gut. It's the Hail Mary pass of vasopressors.
Speaking of the heart, what if the pump itself is failing? We said earlier the heart races, but eventually it must get tired, doesn't it?
It does. It's called septic cardiomyopathy. The heart muscle gets stunned by all the toxins and the inflammation. If the cardiac output starts to drop, we use inotropes, specifically a drug called dobutamine.
How is that different from a pressor?
A pressor squeezes the pipes, an inotrope kicks the horse. It stimulates the heart muscle to beat stronger, not just faster. It improves the pump itself.
There is one more treatment mentioned that seems, well, controversial. Steroids.
IV hydrocortisone.
This seemed really counterintuitive to me. Steroids suppress the immune system. Why would you want to suppress the immune system when you're fighting a massive infection?
It's a brilliant question, and it's why doctors argued about this for decades. The logic isn't to suppress the immune response to the infection. It's to treat something called relative adrenal insufficiency.
Which means?
Okay, so imagine the stress your body is under. It is the maximum physiological stress possible. Your adrenal glands are pumping out natural cortisol, your own stress hormone, to try and keep your blood pressure up. But in severe sepsis, the demand is so high for so long that the adrenal glands essentially run dry. They burn out. They can't keep up.
So the patient crashes because they literally run out of their own stress hormones.
Exactly. So we give low-dose IV hydrocortisone not to fight the bacteria, but to replace the hormones the body can no longer make just to support the blood pressure.
It's like the security guard running out of adrenaline and passing out in the middle of the fight, so you have to give him a shot just to wake him back up.
That's a very good way to view it, yes.
We also have to manage sugar, right? You mentioned that.
Absolutely.
Yeah.
Insulin therapy, sepsis spikes blood sugar, and high blood sugar feeds bacteria and actually hurts immune function. So we try to keep it tightly controlled, usually under 150.
And finally, we have to protect the patient from, well, from the hospital bed itself.
Prophylaxis. When you are paralyzed, sedated, and in shock, you are a sitting duck for other problems.
Yeah.
You can get deep vein thrombosis clots in the legs, so we give heparin. You can get stress ulcers in the stomach from the shock, so we give H2 blockers. We are basically life-supporting every single system, hoping the body can recover.
It is an overwhelming amount of management. You're juggling fluids, pressors, antibiotics, insulin, steroids, heparin, all at the same time while the patient is on the absolute edge of death.
It's the ICU's greatest challenge. The margin for error is effectively zero.
So let's bring this full circle. We started with a security guard burning down a building to catch a single burglar.
And through the science, we've seen exactly how that fire starts. The bacteria, the burglar, drops the lipid A molecule.
Right.
The immune system, our guard, sees it via the CD14 receptor and just panics. He calls in the airstrike with TNF-alpha. That airstrike destroys the building's walls. That's the endothelium. It floods the halls. That's the leakage. And it causes this paradox of clotting and bleeding, the DIC.
And the medical team is outside, spraying water with fluids, trying to fix the walls with pressors, and hunting the burglar with antibiotics, just hoping they can save the structure before it collapses into ash.
That is the story of sepsis, a race against an internal clock.
Before we go, I want to leave our listeners with one specific detail from the text that really haunted me. We talked about steroids and cortisol. The text notes that in septic patients, cortisol levels vary wildly.
Yes, they do. All over the map.
But here's the kicker. The text says mortality is associated with both very low cortisol levels and very high cortisol levels.
That is the profound tragedy of this condition. It's a physiological catch-22.
It suggests that the body's own survival mechanism is completely disoriented. If it doesn't stress enough, you die. If it stresses too much, you also die.
It connects back to the bigger picture, doesn't it? We spend so much time worrying about the external threats, the bacteria, the viruses. But in sepsis, the threat is internal. The body's sophisticated feedback loops, evolved over millions of years to save us, become the very instrument of our death. The survival instinct becomes the executioner.
And the question remains, can medicine ever fully learn to negotiate a truce in that civil war? Or will we always just be racing the clock? Something to think about. That's our deep dive for today. I'm going to go wash my hands.
Probably a good idea.
Stay curious, stay healthy, and we'll see you next time.